started since it's about 4:04 and we have 20 participants, so.
Okay.
Well, good afternoon, everybody. My name is Adeline Clemenson and I'm the chair of We Are Champions. We Are Champions is a membership affinity group of Tucson Medical Center and is housed at the TMC Foundation. Our group provides educational sessions for its members and the lay public. When called upon, we also assist TMC with advocacy measures to help promote TMC being the only community hospital in Tucson and Pima County. There are 9 members of the steering committee who orchestrate and plan our educational sessions and community conversations like this one today. I'd like to introduce our 2 speakers today. Dr. Clifford Martin is an infectious disease specialist and is the former TMC Chief of Staff. He participated in our session on our very first COVID session about 5 or 6 months ago. He graduated with honors from the University of Arizona College of Medicine in 2003. He has over 18 years of experience in infectious disease. He also serves as a board member of the Pima County Medical Society and the Southern Arizona AIDS Foundation. Our second presenter today is Mr. Alex Horvath. He has led TMC's planning and implementation of the vaccine clinic that is rapidly approaching 100,000 administered vaccines. He also is TMC's senior human resource leader. He joins us from Chicago and received a Master of Science from Loyola University. So thank you for your willingness to be part of our panel today. Before I go on with the questions, are there any opening statements that either one of you would like to make?
Dr. Martin, anything?
We have a whole bunch of questions, so.
Sure, I think that a lot of what we have to say will be addressed in the questions that come up. I guess that I would just say it's a pleasure to be back with you all again. I can see some of your faces. It's a very, very different conversation today than the last time we met, although in some ways many of the themes will be very similar. So we'll see where this goes, and I'm happy to be a part of the conversation today.
Thank you so much, Dr. Martin.
And I would echo Dr. Martin. Certainly great to see everybody. Thank you for the invitation. It's great to be on the call. And remember, we're here to really answer any questions you have. And if we can't today, we'll certainly look to find that answer out and get it back to Adeline and out to everybody. So thanks again.
All right, so we asked our members and people who had registered to send us questions. So for the next 30 or 40 minutes, I will be acting as the moderator. We are going to start with some general questions and then get into specific questions regarding COVID and the vaccines that are currently available. And I will leave some time for additional questions from the group at the end as well. So Dr. Martin, the first question is for you. You were with us last October. And so from your perspective, what has the last 5 or 6 months been like at TMC and or any other hospitals?
Well, it's been somewhat of a roller coaster. I think that that's a very fair thing to say. We have been through what I consider now to be 3 surges or upticks with COVID. TMC was clearly at the forefront of taking care of the brunt of those patients that came through. It's been a challenging time, and I think that if you look inside the hospital walls, you'll see that we have had a very significant ebb and flow of seriously ill COVID patients, and we've in the last perhaps month, perhaps a little bit longer, kind of been on the ebb side of that again, where there certainly perhaps a tenfold decrease in the number of patients we have. I would say that at the peak of our last surge, we were really tested to the limits, having sometimes over 120 patients with COVID in the hospital at a time, which really restrained a lot of the other activities in the hospital, and tested especially the nursing staff and the ICU staff, the physicians and the hospitalists, to a degree that was very exhausting. I think now we're at a point where we're still seeing a lot of exhaustion and fatigue in many of the healthcare workers, but also, for the first time, probably a sense of hope that there may be genuinely a true, perhaps not end in sight to COVID, but certainly a larger de-escalation to a point where it's not going to be as much of a threat to the community and to the hospital as before. We certainly have seen a lot more of the normal kind of patients that we see in the hospital. Elective surgeries are on the increase again. So a certain sense of normalcy there, but it's certainly not the place it was a year ago, 13 months ago. I mean, everyone is still masked all the time. And you can feel a sense of hope and a sense of fatigue in a way that I think anyone would expect at this point.
Dr. Horvath, Mr. Horvath, did you want to add anything to that?
I again, heard what Dr. Martin said, and that is so on point. We have found that, staff, after having gone through, as he indicated, a year of the COVID impact, it had a bit of burnout, had the whole anxiety about what does it look like, what does the future look like, and it's been this encouraging kind of resilience and the ability to kind of, we all feel, get to the other side of it, that is really emanating in around the hospital now. And it's interesting because we just put all of our leaders through a course, a workshop called, resiliency training. And we're also offering that for medical staff leadership coming up, an opportunity to get a glimpse of that. But the whole premise of that is to really be ready to help employees get to the other side of this after having gone through the amount of challenges over the last year. And that's really everyone from our key physicians and providers and clinical staff and nurses, but it's also the EVS and dietary and everyone else, because not only were they navigating at work, but also at home and in personal life at the same time. So, I see Donald on, and I see individuals on from the board, obviously, but also from the foundation office. And one little side story: while everything was going on, we had a large presence of volunteers across the organization and also in the Marshall. And they had delivered dinner and lunches numerous times that were those little glimpses of a reprieve, of so appreciative were all of those that were volunteering on the lines of giving vaccines. And it was such a shot in the arm that whenever I see them now, I always think of that, because they brought a smile and such appreciation to so many who were serving for long hours there. So just thank you as well.
So this could be answered by either one of you. We still hear from our colleagues, is it safe to go to TMC or any hospital? And are people still avoiding the hospitals because of COVID? And how is that impacting the hospitals?
Well, I can say that it's safe to go to the hospital. It's definitely safe. At the beginning of the pandemic, I think there were two things that made people nervous. The first was that it was something new and we didn't understand it. So we've come a long way from sterilizing our delivered groceries to the house and feeling like you have to decontaminate every time you come in the house, to understanding that this is a truly very contagious respiratory virus. But now, a year later, we know what to do to prevent the spread. Masks work. That's very, very important fact. It's back to the basics kind of science, but it has proven to be true. So the corollary to that is a year ago, we really weren't quite sure we had enough masks. And so the supply shortages were the real thing, partnered with the ambiguity of what COVID really, how it was really transmitted, that made a lot of people question whether it was safe to come to the hospital. So a year later, I think the answer is yes, it's safe to come to the hospital. We know how it's transmitted, and we have enough PPE at this point. So with those two things being addressed, and with the ability of TMC as an independent community hospital to react quickly and evolve policies in a way that is relatively fast compared to many large bureaucratic institutions, I think that coming to the hospital now is as safe as it can be. I would feel very comfortable coming to the ER if I had to, and in fact I've had to with my elderly parents at one point, and so I experienced it myself and know that it worked very well. There was a second part of your question I'm not so sure I answered, if I remember correctly.
Are people avoiding the hospital because of COVID, and how is that impacting?
I think that's a difficult question to answer more than it was before. It doesn't feel to me like they're avoiding the hospital, because the hospital is full with a lot of people that are very sick from other things. In my specialty, I sure am seeing a lot more of other complicated infections from that don't have anything to do with COVID. So at least from the perspective of someone practicing inside the walls, it seems like perhaps the opposite. Perhaps people that were waiting are now finally seeking the health care they need. It's a little bit of a different question, I think, for routine ambulatory outpatient services, but the hospital certainly is not suffering from volume or work at this point from my perspective as a doctor inside the walls.
Mr. Horvath, you led the planning and implementation of TMC's vaccination clinics. Can you speak to what that involved? How were the vaccines rolled out? How were the vaccine rollout recommendations formulated nationally and at TMC? And where are we now with that rollout?
Absolutely. It was obviously a partnership with Pima County for us, and one of the first levels of our objective with the county was our 1A1, and so from a national level, from the CDC and also from the state and county level, it was really putting together the plan to look systematically at those with greatest exposure to the virus, and then to categorize them in the different categories, 1A1, 1AB, 1AC, and so forth, and move through them systematically. So for TMC, the first opportunity was for us to look at where we could vaccine, and we looked at both the internal large conference center that we have called Marshall, and then also externally at Lot 29. We had a really great team of individuals that included individuals from our facilities, from our emergency planning, from our logistics folks, from our pharmacy, from our employee health. And we were able then to set up a couple systems from information system. One of the requirements was daily reporting, and this is still a requirement, to ACES, to the federal government, exactly what was utilized in terms of your allocation for every one of your vaccines that we are responsible for and accountable for, and had to be reported if there's any waste, and then the second part of it was, were there any types of effects from the vaccine that needed to be reported, any reactions, and so forth. And so both of the facilities started up. We started the internal a day earlier and started the external the next day. And we began doing first TMC and TMC physicians signing up and moving them through. And as we moved through that first wave, we did about 17,000 healthcare workers as part of that first wave. And the county was, and we all collectively were satisfied that we're at a saturation point and pretty well had everyone who wanted to be vaccinated did. From our own employees, we were about 75% of our employees went ahead and got vaccinated with both vaccines. And it's so as we went forward then, we had the opportunity for both Moderna and Pfizer. And then you all know we, as one of the two of the pods in town, Banner had two pods going forward as well, the University, Tucson Convention Center, TCC. And as more and more came online, it was a matter of getting the vaccine. And then when you did, we learned very early that the more that we were able to vaccine in a day, so our goal was, 2,000 a day, the more vaccine allocation we got. So that was really a clear distribution and the way it works. So we were certainly dedicated, and we had a significant amount of volunteers. We heard from one today, Susan, I think, who was out there, and it's been the dedication of the volunteers at both sites that have really been the hallmark for us to be able to get this done. So last week on Thursday, we did our 100,000th vaccine on campus, and that was a real exciting accomplishment for the organization. And I think Susan mentioned it too. We are going to do vaccines. So then along this journey, we did close down beginning for us in March 1st, the Marshall. We felt that we did all we could at Marshall. There were a lot of steps in negotiating, getting through transportation, parking, and everything else. Much easier to do our drive-through, so that we continued with the drive-through. And our last drive-through vaccine there will be on the 15th of April, and then we'll be moving to Udall. In Udall will be a fully air-conditioned indoor with bathrooms, access, and ground floor access for us to be able to do continued throughput, at least through May 31st, and longer if needed, to supplant and to support the county in the overall plan. So right now, we're also happy to say that we've been moving toward Moderna only. That allows us to use only one vaccine. We're finishing out all of our second Pfizers. We did get our first allocations of Johnson & Johnson, and so we've distributed those through our TMC1 practices. And then you probably may know we've done some outreach, and we've done several pop-up clinics that we've supported. In other words, we've taken to socioeconomic and some of the areas of the city that don't have the accessibility. So we did 500 on a couple occasions, and we have another one set up at another church location in April 17th. And our target is to do 700 on that outreach that particular day. And that's an all volunteer crew. So Susan, if you're up for it, we'll be doing more volunteering out there. So but it's been, the reason we got into it, past doing healthcare workers, was because of TMC's commitment to the community, and as a community hospital being in a leadership role to be able to do it. It's been one of the most rewarding things that as an organization we have done on an ongoing basis. It has had instant gratification, as we saw first, as Dr. Martin could attest to. We saw people relieved in the medical field, ready to go to be able to get their vaccine. And then we saw the same manifested on the 75 plus, and then the 65 plus, and the 55 plus, and the different groups that have come through. And, we're really at that, I think we're at about, 40+%, I think it was 44% of the population on the latest numbers. I just saw it today, so that's a fantastic lead for Pima County as part of Arizona's overall effort. So I know that was a long-winded answer, but it's been a long process that many people have supported. Thank you.
So we hear from many of our friends and family members that are still having difficulty getting the COVID vaccine appointments. So from both of you, what do you suggest, and do you have any helpful hints or tips about how they can get their vaccinations?
Okay, I'll take the first opportunity. Well, Um, we have worked extremely close with the county from they have both, and we have both a number for a helpline. And we have dedicated 14, individual employees to that helpline to help get registered and help navigate the My Chart and help navigate those components. And the county has that 222-0119 number that, also if they're busy, also rings to us. And so it's really a cooperative, and the group, if you can get through, and I know that it's been a little bit easier to get through lately, is willing and able to help people navigate the registration process. So that would be kind of the first level, to be able to get registered, get the My Chart, and go through. Secondarily, I think it's been opened up, and there's been more appointments with the longer hours at the U of A site. And so I know they've been continually opening up appointments there and want to continue to do that as well. So that would be kind of the secondary opportunity, to get registered as well. I can say that we also, our TMC1 sites, with our allocations, and maybe we'll get the hours out there. We also will do patients through TMC1, but we'll do others, as well, that are not patients of TMC1 for the Johnson & Johnson, which is a one, vaccine option.
Dr. Martin, do you have anything to add?
I wish I did, but I don't. I am surprised that every time I think I know how to do it, I get another email, and it seems like the popular neighborhood blogs and things like that always seem to be one step ahead of me. I think my advice is just don't give up. Keep looking at the county website and keep reading the newspaper, and eventually we'll all get there. I would be giving misinformation if I gave away a tip, because I'm pretty sure it would be the wrong tip tomorrow morning. It's evolving so quickly.
It does. Yeah.
So, Dr. Martin, this question probably will be for you. We have been hearing a lot about variants around the world and in the US. Recently, it was announced that a variant was present on the U of A campus. Which one was it, and how do we keep this or these variants from affecting us? In your opinion, do you think we are going to have another surge, and how protected are we with the current availability of vaccines against these variants?
So it's interesting. The variant that I understand was detected at the university was the B117 variant, if I'm correct, unless there's been some updated media since that time, which has been also described as the South African strain. And it is one of the strains that has emerged as this virus mutates around the world, as one that has been described as being more easily transmitted and also potentially more deadly for the patients that have severe disease from it. So it's interesting that it's been described at the University of Arizona. It's been described at a couple of other places around the country that are doing sequencing, but I think there's a couple of points to be made. First is that for reasons that are difficult for those of us in medicine and in healthcare and science to understand, the United States has really not been on the cutting edge of sequencing these viruses. It's pretty clear that the United States and our pharmaceutical industry has been on the cutting edge of producing vaccines. That's obvious. There are plenty of countries and places in the world that are, not vaccinating anybody yet. So we're clearly on the cutting edge of that. But there have been other places in the world, Israel, Ireland, a few other places around the world, that have been actively sequencing these strains and characterizing them. And the US has not been a place that has done that. So the fact that we're detecting it in Tucson and in some other places around the country probably means that it's much more ubiquitous than anybody realizes. So that's just worth commenting on. And even this last week, as I was reading the literature, I identified a report of a strain that had been sequenced that I had not even yet heard of before. So this is constantly emerging. So the science of it is interesting, and the politics that has led to the science is interesting, but the real question is, what do we do about it? What do we do about it as a community from a public health standpoint? And what do we do about it as individuals who want to protect ourselves and our families? And I think that's the other part of the question you asked. So the good news is that despite some prediction or concerns that the current vaccines may not be as effective against some of these newer strains, at least even within the last week or two, it's become pretty clear that the vaccines that we are using here are pretty darn effective against these newer strains. So that's the good news. Even the B117 strain, the Moderna, the Pfizer, and the Johnson & Johnson vaccines seem to have pretty darn good efficacy against. So at least for the time being, the mutations have not emerged anything that I think are an immense concern for a lung. That doesn't mean things can't change. The coronavirus is an RNA virus, and it does lend itself to mutations in a way that are much more frequent than other types of viruses. We talked about that, I think, the last time we were on the Zoom. The hepatitis A, B, and C are viruses we're all familiar with. We have good vaccines for hepatitis A and B because they're DNA viruses, but hepatitis C is an RNA virus. Mutates more readily, it's a little more difficult. So coronaviruses is in that broad category. So I don't think that, I think that the message that I have given to people and I've given to the media on the few times I've had to talk to them is there's cause for hope. The vaccines that we have seem to be very, very effective, even against some of these emerging strains, but we can't let our guard down. There's always a possibility that something else could emerge that could be resistant. I think that's low probability, but certainly a real possibility. And so the message once again is back to the basics. Keep wearing your masks, keep social distancing, let your guard down a very little bit with other people who have been fully vaccinated within your circle, and encourage everyone we know to get the vaccine.
So before I go on to our next prepared question, in the chat, we have a question that says, we're beginning to encounter people who refuse to get the vaccine, not trusting the science or because of politics. Please share comments on best messaging to them.
You know, I get a little emotional when I hear this question. And I think the reason is that for those of us who have been in the hospital, this is so real. And it's really hard for, it's really hard for me to know how to answer this question. Because if you've taken care of people who have died from COVID or who have been severely ill from COVID or talked to their families, it's a really sad thing to hear people that are poo-pooing a vaccine that's looking so effective. So my strategy has been, every time I can speak to it, is to tell a personal story of what it's like to suffer and die or lose someone close to you from COVID, and then try to talk about what it feels like to know that you're protected. There's a psychology of prevention that is elusive to even the best minds in healthcare. It seems like no matter what we do, there's always a segment of the general community that seems to be resistant, whether it's for cultural reasons, either because their ethnic or cultural groups have been discriminated against in the past, or even in the worst case scenarios in our history have been experimented on in the past. And then there's a political slant and a religious slant that occasionally weighs in. So I have not found in my personal communications with a larger audience that just quoting the science is helpful. I just try my best to tell a story that's personal so people can see the heart of it and maybe make a better decision. That's the best answer I think I can give.
Thank you. So one of the questions from some of the membership was, does the blood type have anything to do with who may get COVID-19 more so than another? And who are the most vulnerable to get the COVID-19?
So there have been all kinds of studies over the last year that are sort of science in rapid action to sort of characterize risk factors and treatments, et cetera. And so there have been some interesting things where people have published certain blood types or other predisposing risk factors are more or less at risk from developing COVID. One of the studies I read indicated that blood type O perhaps was a little more severely affected. I personally have not found anything in that literature convincing enough to hang a hat on. For example, I wouldn't take that literature and recommend that we screen people for blood type when they present to the hospital or in the clinical setting. So nothing has been convincing. But I think that my take on all of that research is that it's really fascinating to see how quickly many of these sort of case series or patient series of investigations looking at risk factors kicked in. We're really seeing science in fast forward motion here. These are the types of questions that we usually ask over periods of years and years and years as we survey genetic risk factors or cultural risk factors or comorbidity risk factors with thousands of patients that help us inform preventive efforts and treatments. And we're seeing it all in a microcosm. So I think that it's interesting that blood type may or may not be a serious risk. But that's the way I look at it. It's kind of exciting to see how fast all of these case studies and characterizations of patients are coming out. I'm personally very interested in some of the emerging research that's being done, less on people who are more at risk of getting COVID, but along the lines of people who are more at risk for developing what is being called long COVID or the post-COVID syndrome. It's a small percentage of patients, there's no doubt, but there's a large emerging group of them that are actually suffering quite a bit. So I'm curious to see where that all goes. I think I answered the first part of your question. Was there a second part?
No, that's
Okay.
good. Again, a lot of these questions are going to be directed to Dr. Martin, and then we'll get back to some that will be directed back to Mr. Horvath. So in your opinion, Dr. Martin, are the vaccines safe, and have the vaccines caused any health problems to otherwise healthy patients to your knowledge?
So I can tell you that they are very safe. Absolutely. There are plenty of reports of adverse reactions or bad things happening. But when you look at the data, this vaccine is just as safe as or safer than other vaccines that we routinely give. So while the adverse reactions that capture the imagination of people who are hesitant to take a vaccine that's relatively new or who may otherwise, be predisposed to not have great uptake of vaccines or other modern healthcare interventions. This vaccine is, like I said, very, very safe, and the statistical prevalence of side effects is not beyond what we expect from any other vaccine, and in some cases it's less.
So as a follow-up to that, if someone is pregnant, nursing, or has an underlying condition, can or should they get a COVID-19 vaccine?
So right now, so I'm not a pediatrician or an OBGYN doctor, but I get asked this all the time. Right now, the recommendation is yes. So right now, as far as we understand the science, the CDC and other bodies like the Infectious Disease Society of America are recommending proceeding with the vaccine. Yes. In fact, those immunocompromised patients, I think we have enough evidence to say that they should go ahead and get it, and it's very safe in those populations.
So can someone get vaccinated against COVID-19 while they are currently sick with COVID-19?
That is one of the cases that we don't give it. It's kind of a general principle with infections that if you're actively infected, we usually don't give you a vaccine to it. But we are, at least the recommendation currently is once you've recovered and a certain amount of time has passed since you were afebrile and you had recovered from the symptoms, to go ahead and get it. Very similar, for example, the shingles vaccine. We don't give the shingles vaccine if someone has active shingles, but we do recommend it after they've recovered, a few weeks or months afterwards.
Yeah, that was one of the follow-up questions, that if you've already had COVID-19 and you've recovered, do you still need to get vaccinated, and why and when?
So the answer right now to that question is yes. That's the recommendation. This is, an emerging area of science and understanding. But in that scenario, it's really an immune booster. And I wish I could comment a little bit more on the true science behind it. But yes, right now the recommendation is to go ahead and get the vaccine once you've recovered. There have been some cases where we've recommended waiting a little bit, but I think that was more due to supply issues. Right now, I'm advising all of my patients to get it.
Okay. What can people do when they are fully vaccinated? Are there any activities that should not be done even though you're vaccinated?
So one of the interesting things about vaccines is that they're not as black and white as I think most people think they are, and they're not as black and white as we wish they were. I think about it in terms of the influenza vaccine, which I'm not comparing COVID and influenza, but people will always say, "Oh, I got the flu vaccine, but I still got the flu, so it didn't work." And my message to them is, well, if you got a cold and a runny nose and a little body ache, and 3 days later you were better, that means the vaccine actually worked. You didn't die from the flu, and you didn't end up in the hospital. The point of it is to boost the immune system. So with the COVID vaccine, it's the same concept. First of all, just because you get the vaccine or you've had COVID before doesn't mean you can't get it again. It's pretty clear that if you do get it, the symptoms might be very mild, but we don't know yet very much about whether that person will then spread it effectively to other people who have not been vaccinated. So right now, the recommendation is if you've been vaccinated, you really should continue doing everything that you've been doing all along. The social distancing, wearing masks in public, et cetera, et cetera. But if you're in a group of people who have also been vaccinated, especially if everyone has completed both of the doses, and everyone is asymptomatic and everyone's afebrile, that's as safe as you can get now from having smaller social gatherings, people that are unmasked, et cetera. Just as long as you're, taking into context the health of everybody that's involved. I mean, I had for the first time in a year, had a small birthday party for a friend the other day, 6 people, all of us, 3 of us in healthcare, 3 of us spouses. We were all vaccinated. We were all healthy. We all knew we weren't having fevers. And oh my gosh, we had dinner together without masks on. It was beautiful. That's the setting that the CDC is saying is safe to do it now, and I concur. But going to the grocery store, all of those things, back to the basics. Just continue to wear masks like you were before. I think we're going to learn more and more. I think the answer to that question may be different in August or September as the uptake of virus continues around the community. But for the time being, that's my answer.
How long does protection from the COVID-19 vaccine last?
Well, we don't know the answer to that question yet either, because it hasn't been around long enough. But as far as we know, based on early population studies and detection of antibody after getting the vaccine, it at least lasts 6 or 9 months, at least. But I think people are predicting that it's going to last much longer. But even though you can predict that based on population studies and antibody studies, the real answer to that question is going to come in the future. Right now, though, we know it's going to last at least 6 or 9 months, and probably much, much longer.
So as a follow-up to that and to your answer, do we know if it will ever get to a situation where we may have to get an annual COVID booster shot, just like we get the annual flu shot?
It is quite possible, and it's also quite possible that it may be something more along the lines of the pneumococcal vaccine or other vaccines where you get a booster 3 or 5 years later, or some of the childhood vaccination series where you probably remember you get 2 doses when you're a certain age and then another booster when you're 8 or 12 or 16 or whatever. Whether it's annual or whether it's on a more spaced out period, I think is to be determined, but I think it's very possible that it's not going to be a one-time thing and then you'll be immune forever. There's probably going to be some sort of a booster dose in the future.
What is the value of a vaccinated traveler getting a COVID-19 test 3 days before a flight, as has been suggested by the CDC?
Well, I think it boils down to the idea that you still could spread it. I think that's really where we're at right now. When you're in a closed environment like that for a period of time, even if you've been vaccinated, if you were recently exposed, you may not develop symptoms, you may not be ill, but we know from other viruses that those people could still potentially spread it. So in my opinion, that's more of a public health recommendation than an individual health recommendation. And so that's the way they're doing it right now, is my understanding, at least in most places. It's interesting to make a differentiation between what the public health authorities are recommending for general population and then what individual patients need to understand to protect themselves and their family. And I think the psychology of that and the nature of who's making the recommendation is an interesting thing to observe in real time as well about COVID, because many of the recommendations like that probably don't have anything to do with the individual person that is getting tested, but the public health implications make sense.
Can you please talk to us about the concept of herd immunity and how do we get there? And how difficult is it to achieve herd immunity, and what risks are associated with herd immunity today?
So herd immunity is a concept that is really more of a public health concept than an individual medicine concept. It's along the same lines of what I was just talking about. Public health people, infectious disease, epidemiologists take into context what we know about how easily a virus is transmitted from person to person, and how long it takes for that particular infection to develop symptoms inside of a person, how it's transmitted, and then they can apply statistical and epidemiological algorithms to decide to predict how many people in the population need to have immunity to an infection before it will spread very readily in the population. So the SARS viruses, the initial SARS virus and this SARS-CoV-2 virus that we're calling COVID, they spread very quickly. They spread very efficiently. They're very contagious. They develop severe illness quickly. And yet there's a large number of people that are asymptomatic that can still spread it. So that's a very different model than something like, say, HIV, which is obviously spread in a very different way. And it takes 7 years, for example, before you develop any symptoms. So based on all of that, they can tell by statistical modeling how many people in a population need to be immune before it can really stop spreading very efficiently in a population. That's probably a little bit of a technical explanation, but it's hard to bring the concept home without a little bit of a comparison like HIV or other infectious diseases. So based on that modeling, the best prediction is that once about 70 or 75% of the population in a particular area or a particular country or a particular region have antibodies, then the virus will stop spreading as efficiently as it is now, and we can let our guard down. That doesn't necessarily mean that individual people won't be exposed and that individual people won't get sick. But if they do, it's not going to spread like wildfire, like it will in an unvaccinated or an unexposed population. So 70 to 75% is what they're predicting now. And that immunity could come from either having been infected with the virus and then getting over it or being vaccinated. Individual people could still fall ill from it, but the risk of it then spreading in a large population is dramatically decreased.
Okay. To your knowledge, are there any other viruses we should be concerned about that are on the horizon?
Right now, I'm not aware of anything on the horizon. I mean, within the last few weeks, we've read about Ebola in Africa again. I've never personally thought that was a major risk to the United States just because of the way it spread. Certainly, if it were to come to the United States, it could be a risk to a small group of people, but it's not spread like respiratory viruses. The coronaviruses, this whole family of coronaviruses is one of the ones that has always been on the back back of the minds of public health officials simply because of the way it's spread. I think the largest threat really continues to be the stuff we know about already. Seasonal influenza, which can mutate, which is why we get vaccines every year, is probably the other number one threat in terms of risk to large populations. I don't know of anything new and exciting other than that on the horizon.
Okay. So we'll give Dr. Martin a quick break here and we'll go back to Mr. Horvath. And you talked a little bit about what TMC was doing to help underserved communities in and around Tucson that may not have access to getting the vaccine. And can you speak a little bit more to the older adult population or anyone else for that matter who are homebound or having difficulty accessing a vaccine site?
Yes, so we have gone ahead and partnered with the Pima County Council on Aging. And so each and every day we look to vaccine and put on the schedule at Lot 29 individuals that have been identified by that group. And it's usually 15 to 20 individuals a day that we will vaccine, and they'll fall into that 75 plus. Also, many times without the right connectivity, the right resources. In addition, the county, through their navigators who are really focused on a lot of our socioeconomic and areas that perhaps have some uneven distribution of vaccine and some disparities relative to health, identify individuals, and they've set up a network of transportation for them that are usually a bus, sometimes a Uber, sometimes a cab, and so forth. And we're doing 40 of those individuals a day, again at Lot 29. The county has gone ahead. There was some federal support with a third party to do in-home and in obviously care centers and senior centers for identified populations, and they've been doing that successfully with vaccine. I know they've deployed a lot of J&J for that recently as well. So from the senior, and then again, that is also one of our key identified groups. At the Rising Star Baptist Church coming up, as I mentioned, on April 17th, we're targeting 700 individuals there, and a lot of it is different ethnicities, but also in the older population that may not have access.
One of the questions in our chat is TMC still doing the monoclonal antibody treatments?
Yes, at our El Dorado location. And so that is done several times a week there. We've moved it under, you probably all know or may have remembered that the CDC and we had a federal team out here that was administering that. We had trained under them, and then it is now under one of our directors who also does the infusion clinic for TMC. And so that continues to move forward with some success.
Right.
Dr. Martin, is there anything else in there I'm missing? Is that?
No, not to my knowledge. I think that's
yeah. Okay, thank you.
So one of our members in the chat wanted to know what that is exactly. So
yeah, the monoclonal antibody is basically an antibody infusion that so there's antibody infusions that are from patients that are collected that are not filtered. So not that they're not filtered, but they don't differentiate the antibodies. So there's a difference between monoclonal antibodies and immunoglobulin infusion. So you can take serum or antibodies from a patient that has been exposed to something, and you can then give them to somebody else. Plasmapheresis, for example. And what you're doing is just infusing all of the different kinds of antibodies in the hopes of that some of those antibodies will be effective in treating something in the new patient. A monoclonal antibody, on the other hand, is an antibody that is very specific for one type of target. So in this case, the target would be the coronavirus. So these monoclonal antibody infusions are antibodies that are already preformed, and you're injecting those antibodies directly into the patient. So it's different than the vaccine, which does the same thing, except it makes your own body produce the antibodies. In this case, you're giving the antibodies directly to the patient. And so these antibodies are being used in these clinics. They've been studied and thus far been proven not so much to be effective in patients that are already in the hospital and sick from COVID, but in people who develop COVID and are at risk of progressing disease, we can give these antibodies in the outpatient setting, and it's been shown to decrease the risk of those patients developing worse disease and needing to be admitted to the hospital. I don't know how many clinics there are in the country, to tell you the truth. Kind of a moving target, but TMC is one of the places that's been doing it from the get-go since it's become available.
There was a follow-up question also that is as follows. Is it safe to fly if one is vaccinated and the people we are going to be with when we arrive are also vaccinated? What if we are not vaccinated? Is it safe to fly?
Everything is relative, right? Like, has it really ever been safe to fly? Like, I don't know the answer to that question. I do it all the time, right? But how many times do you fly and you get a cold afterwards? I mean, you're in a tight spot with all these people. I think you can do it right. I think you can do it right. I think that if you take the appropriate precautions, you wear the appropriate kind of mask, you have your hand gel, you're aware of your environments, it's safe. Is it foolproof? No. I think certainly if you've been fully vaccinated, it's dramatically safer than it used to be. I know plenty of people who have flown because they've had to, and they've done just fine. It's not black and white, but if you have conditions that predispose you to severe disease, whatever those may be, other medical comorbidities, obesity has to be on the list, etc. And you haven't been vaccinated, I would advise my patients at this point not to do it unless it's necessary. Get the vaccine as soon as you can. But if you have to do it, just take the right precautions, and most likely you'll be okay. I have a handful of experiences with patients who have flown and just done fine, and I have one or two patients that weren't vaccinated yet, and they did everything absolutely the way they were supposed to, and then they came down with COVID. So it's a tricky virus, but I would say avoid it if you haven't been vaccinated, and if you have been vaccinated, you still need to take the same precautions to be safe.
Thank you. So we're almost out of time. So I would just like to take this opportunity to thank Mr. Horvath and Dr. Martin for sharing their expertise and experience with us today. And I would also like to thank the TMC Foundation staff, particularly Julie Wolf-Beadle and Megan, for helping to make this event possible today. There is another COVID vaccine town hall that's coming up, sponsored by TMC. It's called I'm Vaccinated, Now What? And it will be a town hall Zoom held on April 7th at 2 p.m. And if you're interested, you can see the TMC main website for further details. Our next We Are Champions lecture focuses on a healthy heart. It will be held via Zoom on Wednesday, April 28th. Featuring the cardiologist from TMC, Dr. Neil Jawala. And this lecture will feature your cardiac health and the cardiac innovations occurring at TMC. So there's one more question in the chat. Before I end this, let's just see what that is. And, oh, no, I think that's it. Okay, so thank you all for joining us today. We have recorded this session and we'll be sending everyone who registered a link to review it and/or forward it to others. If you would like to become a member or renew your membership as We Are Champions, there will be a link in the email to do either one of those. So again, thank you very much, Dr. Martin, for joining us again. Thank you, Mr. Horvath, for joining us for the first time. We look forward to having both of you when we have really, really good news to share about the COVID and the vaccine. So thank you for everything that you're doing for TMC and our community, to both of you.
Thank you very much. Take care. Bye. Bye, y'all.
Bye-bye.